Hi, welcome back to our new educational quick video. I'm Erin from Educated Nurse, and today we're going to talk about ventricular dysrhythmias. So PVCs, premature ventricular contractions, Vtach, ventricular tachycardia, ventricular fibrillation, or Vfib, and asystole. If you're new to us, follow us, like and subscribe on YouTube, follow us on Facebook and Instagram. And then we also have a store on Etsy and Shopify where we sell study guides, merch, and some other templates for your nursing or EMT or paramedic school experience. All right, let's dive into ventricular dysrhythmias. All right, just as a good reminder for normal sinus rhythm, all 10 things need to be there in order for it to be normal sinus, right? You need these 10 criteria. The rate should be between 60 and 100. The rhythm and regularity should be normal and regular. All the P waves and all the QRSs should march along in a regular fashion. There should be a P wave. There should be a P wave before every QRS. Your P, your PR interval, your QRS, all those measurements should be normal. Check out the normal sinus rhythm video if you need help memory or remembering those measurements. The ST segment should be at baseline. There should not be any elevation or depression. There should be a T wave, that's normal. There will not be a U wave, and there will be no early beats and no late beats. So in order to meet normal sinus rhythm, you need all 10 of those criteria. Let's dive into some ventricle arrhythmias here next. All right, premature ventricular contractions or PVCs. So like I talked about in the atrial dysrhythmias, normally in a normal healthy beating heart, the atria beats and then the ventricle beats. In a rhythm or in a normal fashion, beat, 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 squeeze, 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 squeeze. The SA node fires, sends an electrical impulse across the atria to the AV node and then down the Purkinje fibers in the ventricle squeeze. All right. The SA node is the main pacemaker of our heart. However, like I said in the atrial dysrhythmia video, any cell in your heart, any cardiac cell, has the ability to be its own pacemaker. That's when we run into issues with PACs, PVCs, atrial fib, atrial flutter. In a PVC, what happens is the atria beats, and then the ventricle beats, and then every now and again, the ventricle just beats by itself. A PVC happens because there is an ectopic foci, or a rogue cardiac cell somewhere in the ventricle that says, I want to beat all by myself. I don't want to wait for the SA node. I'm just going to beat all on its own. So what happens is the heart's cruising along. Atria, ventricle, and then all of a sudden there's some little irritable site or cell in the bottom of the ventricle that says, nope, I'm not waiting for the SA node. I'm just going to fire. And that's how you get these PVCs, okay? When you see PVCs, they're going to be a wide, ugly, bizarre looking QRS complex. They're not going to be nice and narrow. They're going to be wide, ugly, and bizarre. When you look at this one, this particular EKG, you can see that there's kind of different shapes to these. One, the PVC is upright, and the other one is, kind of has a downward deflection. That just means that there are two sites in the ventricles that are throwing out PVCs. Okay, so when they look different or have different shapes, it's coming from multiple sites in the ventricles. So when we look at our 10 points to normal sinus rhythm, you can see that a lot of these things are not normal. The heart rate is going to vary, and that's going to depend on the underlying rhythm. You can have PVCs in normal sinus rhythm. Your underlying rhythm can be normal sinus rhythm, and then every now and again you have a PVC. That's actually pretty common. You can also have PVCs in atrial fib, atrial flutter, other abnormalities. So the heart rate is going to vary a little bit depending on what the underlying rhythm is. In this particular instance, this person is in normal sinus rhythm with a multifocal PVCs. Okay. The rhythm irregularity, it's irregularly irregular. And that is for a couple reasons, right? So these early beats, there's no rhyme or reason to when they happen, so it's irregular, and they're multifocal, so that's irregular. Sometimes PVCs can have some regularity to them. They can occur every other beat, okay, which is bigeminy, or every third beat, which is trigeminy. They can occur 2 at a time, which is a couplet, okay? So there can be some regularity to them, but most of the time it's irregular. They just happen whenever. When we really get worried about PVCs is when there's 3 of them in a row. Okay, three of these PVCs in a row. The patient is at high risk of going into Vtach, because then the atria aren't beating, and somewhere in the ventricle there's some irritable site that's firing, and the patient can go off into Vtach. So that is a concern. So if you have a patient who's clipping along and they're in trigeminy every third beat, and then all of a sudden they go to couplets, I would start to get worried about that patient, because they're getting closer together and there's more PVCs than there are regular beats. That can be a problem. The P wave on a QRS, we can't see. It's hidden or it's buried within the QRS, so we can't measure that. Because of that, and because there's no P wave, we can't measure the PR interval. The QRS, like I said, is ugly, wide, bizarre, distorted looking, and depending on if they look the same or if they're abnormal, it could be multiple sites. The ST segment should be at baseline. There are T waves, there are no U waves, there are early beats, but there are not late beats. So the early beats, the patient will likely feel. So, and we're going to talk about that in just a second. But you can kind of see that the PVC meets a bunch of abnormal criteria. So it's definitely not normal. All right, so what causes a PVC? It can occur in a healthy adult for no reason. A lot of times these are also related to stress, lack of sleep, electrolyte imbalances, caffeine, nicotine, smoking, alcohol, epinephrine. If you're going to give epi for like an anaphylaxis, you can see this. Sometimes patients on digoxin, other stimulants, cocaine, methamphetamine, exercise, hypoxia. Hypoxia is another big one that I have seen a lot. Electrolyte imbalances for sure. Stress and caffeine are big ones. Stress and caffeine are big ones. And you can certainly have PVCs too if the heart is under stress or disease. So like someone with heart failure, or someone who's having an MI or going to have an MI, you can certainly see that too. Symptoms, what are they going to feel? Well, they can be asymptomatic. They might not even know that they're having them. I mean, I just had a patient last night who kept telling me he felt like his heart was skipping a beat, but he was primarily asymptomatic. Otherwise, he was just like this marathon runner, and he just thought it was because he was dehydrated. Well, I hooked him up to the EKG. I'm like, oh, you're having multifocal PVCs here. And he's like, oh, is that what that is? So he really had no idea. He just kind of felt like this fluttering in his heart, but otherwise he didn't really mention anything else. Other patients will definitely feel that heartbeat, right? So with a PAC, they might feel it kind of skip, but it goes back to normal. With a PVC, some patients, like I've had them myself, and I kind of feel like, when someone comes up behind you and scares you and you're kind of like that, I feel that pause, and then I feel like a big slamming in my chest. And the reason that you feel the pause is because it should be atria ventricle. But when the PVC happens, the ventricle beats before the atria. So the atria pauses. And then because the ventricle is filling up again and squeezing, you feel that, right? When we feel a pulse, we feel the ventricle squeezing. So we feel that kind of big boom of the ventricle squeezing when it's not supposed to be. Some patients will even have chest pain. What do we do for treatment? You might not have to do anything. Some patients are, like I said, asymptomatic where it doesn't bother them. The biggest thing is eliminate stress, eliminate caffeine, eliminate alcohol, eliminate stimulants, do the non-invasive things first. Watch out for those runs of Vtach. Watch out for those PVCs that happen 3 in a row. Support oxygen, ABCs, so oxygen, breathing, circulation. Give them fluids if they're dehydrated. Replace electrolytes if you need to do that. Like I said, remove those stimulants. Treat the underlying cause. And if there really is no underlying cause, cardiac meds like beta blockers can be an option. Most of the time with PACs and PVCs, you're going to need to see a cardiologist to make sure that there's not some electrical imbalance that's going on. And usually they'll put like a Holter monitor on and they'll monitor how many of these you're having, and then they'll kind of decide treatment from there. All right, next up is Vtach or ventricular tachycardia. Oh, this looks scary and wide and bizarre, right? Yes, I would be scared if I saw this. I have only seen a couple of patients that are in stable Vtach. Most of my patients that are in Vtach are unconscious unresponsive. So what's happening during Vtach? Look at all these abnormalities when you're looking at your 10 points to normal sinus rhythm. Nothing is normal, right? So what happens with Vtach? It happens because there is a weird foci in the bottom of the ventricle that is beating super fast that ends up taking over for the natural pacemaker, and that becomes the pacemaker. So the atria are not firing at all, because otherwise we would see the SA node fire with a P wave and we would see that PR interval, and we're not seeing any of that. We're only seeing the ventricle squeeze here. So there's some irritable site in the ventricle that's causing this, Vtach to happen. And it's taking over control of the heart's pacemaker. So the atria and the SA node and the AV node are not firing at all here. We get concerned about Vtach when we have a run of 3 or more PVCs. In Vtach, the ventricular rate, you're not going to measure the atrial rate because there's no P waves. The ventricular rate is going to be between 150 and 250, and it's going to be irregular. You're not going to measure a P wave. There's no PR interval. The QRS is going to be really wide. You're not going to see an ST segment. You're not going to see a T wave. You won't see a U wave, and there won't be early or late beats. You're just going to see the ventricles squeezing. It's going to be a little bit more organized than Vfib, and you'll see that in a minute. But either way, this is not good. We have non-sustained Vtach, which is less than 30 seconds, and sustained Vtach. Now, if you think about this, the atria are just sitting there, right? And the ventricle are squeezing. Think about what happens with cardiac output, okay, decreased, right? And I actually had a patient one time in sustained Vtach for like 4 hours. I could not believe my eyes, you guys, seriously. I was like, oh my gosh, how are you awake and talking to us? And I looked up at the monitor, I'm like, this can't be right. You're awake and you're talking to me. I just can't even believe it. It was like 4 hours, and cardiology had to come down, and we had to cardiovert him like multiple times. And nothing was working. So they ended up taking him to the electrophysiology lab to get his heart to calm down. It was bad. He ended up having a bunch of scar tissue in his heart, and it was just out of control. Most patients are going to be unconscious unresponsive, and we're going to talk about that and what symptoms look like in just a second. All right, so what causes Vtach? It can have no cause. It can be idiopathic. These are the kinds of patients that you see just drop, right? And they have some sort of sudden cardiac arrest, or they just are out cruising around and all of a sudden they just drop. Their heart goes into this lethal arrhythmia, and if no one's around to do CPR or shock them, they die, unfortunately. But there can be no cause. It can be what's called idiopathic. We just don't know why it happened. It can be from a run of 3 or more PVCs in a row. So again, we worry about those PVCs if they get closer and closer together. It can also be from other cardiac conditions, so like a heart attack, long QT syndrome, coronary artery disease, cardiomyopathy, drug toxicity, and electrolyte imbalances. And again, it can be stable or unstable, okay? In a stable Vtach, most patients are not going to last long in stable Vtach, except my one like crazy 4-hour, just absolute freak of nature patient that I had. If the patient is awake and they have a pulse, they're going to have severely decreased cardiac output. So you're going to have to support their ABCs. Okay. If they're unstable, they will have no pulse. They will be unconscious, unresponsive. You need to act immediately. So what is treatment? If they're stable, you want to quickly treat the underlying cause. Support their ABCs. You can try amiodarone, lidocaine, or cardiovert them. Quickly cardiovert them. And we talked about cardioversion in the SVT lecture in the atrial dysrhythmias. If they're unstable, they have no pulse, they're not breathing, they are unconscious, unresponsive, you need to start CPR. Do not delay CPR to go grab the defibrillator. Delegate and someone go get the defibrillator. You start CPR right away. You want to defibrillate. You can only defibrillate 2 rhythms, Vtach and Vfib. You cannot defibrillate asystole. There's no electrical activity for the defibrillator to pick up on shock. Vtach and Vfib are the only ones that you can defibrillate. Okay, so CPR right away, defibrillate as soon as possible. And if you're thinking about medications, you can give epinephrine, 1 milligram every 3 to 5 minutes, and then amiodarone. And the dosing is kind of dependent on your physician. Normally you start at 150, then go to 300 milligrams. If there is an electrolyte or acidosis imbalance, you want to correct that as soon as possible. So get that IV started, get those labs, start CPR, defibrillate, and then consider some cardiac meds, which you should learn if you take like an ACLS or advanced cardiac life support class. So this slide just shows you just quick little unstable Vtach treatments, CPR, defibrillate, and then get those meds going. Consider a definitive airway, and then really support the patient with CPR, adequate CPR, good depth, good compression, and defibrillate as soon as possible. All right, next up is Vfib. So thinking about Vtach, you can tell that Vfib is similar. One thing you'll notice with Vtach is that the amplitude on those QRS complexes was higher, right? And then Vfib, it's a lot smaller. There's a lot more electrical opportunities, I will say, for the defibrillator to pick up on Vtach than it does Vfib. The finer it gets, the less electricity is available for that defibrillator to pick up on. So it's super important that you start CPR and you defibrillate them ASAP. Just like Vtach, none of the 10 points to normal sinus rhythm are going to be there. You can't measure the rate. You can't, it's not regular, it's irregular. You cannot measure anything else. Mechanically, the atria is not doing anything. And the ventricles, instead of squeezing like in Vtach and trying to get some cardiac output, in Vfib, the atria are not doing anything and the ventricles are just quivering. They're not even squeezing, they're just quivering. Okay, so think about cardiac output. I mean, it's going to be not much, right, of anything. Vtach to Vfib is only going to be seconds to minutes. And then Vfib to asystole could also be seconds to minutes. So you really need to intervene quickly to convert this patient with a defibrillator if you can. This is a lethal dysrhythmia. The heart rate is not going to be measurable. The rhythm is irregular and chaotic. There is some electricity, which is the only good thing, but you have to intervene quickly. So what causes Vfib? Well, just like Vtach, it can be idiopathic. We just don't know. It can be one of those lethal heart rhythms that causes someone to drop just like that. We just don't know. It can be from heart attacks, heart failure, electrical shock, like if you are outside on the golf course and lightning strikes and you get shocked, or if you have an electrical outlet shock or something, it can cause Vfib, that kind of disruption in electrical activity. Hyperkalemia, hypoxemia, acidosis, and some drug toxicity can also be causes, but mainly it's going to be your cardiac causes. Symptoms in Vfib, your patient is not going to have a pulse. There's no stable, unstable. They are not going to have a pulse. They're going to be apneic, so they're probably not going to be breathing, and they're going to be unconscious, unresponsive. How do we treat it? Immediately start CPR, right? No pulse, not breathing, unconscious, unresponsive. No pulse, unconscious, unresponsive. Start CPR, right? Start CPR, delegate someone to go get that defibrillator, defibrillate them as soon as possible, but don't delay CPR to go get it. Okay, meds, same as Vtach, epi and amiodarone, and then fix your acidosis and electrolyte problems. All right, so just like Vtach, your Vfib treatments are the same. CPR, defibrillate, and then get your meds going. Consider an advanced airway. Keep that CPR going until you are defibrillating every few minutes. Just keep it going until you get return of spontaneous circulation, hopefully. All right, the last ventricle dysrhythmia, if we want to call it a ventricle anything, because there's no electrical activity. This is asystole. All right, so no electrical activity whatsoever is happening here. You cannot measure anything, nothing about it is normal, does not meet the criteria for normal sinus rhythm. This is a flat line. There's no electrical activity happening. Your patient's going to be unconscious, unresponsive, and you're going to have to act right away. All right, so causes of asystole, it's mainly going to be cardiac stuff. Untreated Vtach, Vfib, a heart attack, heart failure, it can be idiopathic. Most of the time it comes because Vtach and Vfib haven't been dealt with in a quick enough manner, and then the patient goes into asystole. So like I said, when you defibrillate, you want to capture some electrical activity. There's no electrical activity in asystole. So the patient's going to be unconscious, unresponsive, not breathing, no pulse. So if you don't intervene, this patient is gonna die. This is a lethal heart rhythm. With this patient, the only thing that you can do is CPR and epinephrine. You cannot shock this. So regardless of what you see on TV or on Baywatch or whatever, that flat line, if your patient has a flat line, you can't shock that. A defibrillator will not work. It'll say no shock advised, continue CPR. So CPR and epinephrine is the only drug that you can try here, and then try and fix acidosis. When you go into ACLS class, you learn about H's and T's. You can try and fix some of those things, but really CPR and epi is where you got to go. And then it's up to the physician how long you decide to work that. But again, no defibrillation on asystole. All right, so just a quick little picture here for asystole treatments. High quality CPR and epinephrine are all that you can do. Hopefully you can get with adequate CPR, hopefully you can get them back to a Vfib or a Vtach so you can defibrillate them. Or you get them back and they have return of spontaneous circulation. But good quality CPR and epi is where you're at for asystole treatment. All right, thanks for watching this quick video on ventricular dysrhythmias where we covered PVC, Vtach, Vfib, and asystole. Follow us on Facebook and Instagram, like and subscribe to us on YouTube. There's going to be tons more videos in the next few weeks as we cover all the body systems. If you're struggling with EKGs or you just want some more information, I have a 50-page study guide with practice questions and EKG interpretation at the end, along with other templates to help you with your EMT, paramedic, or nursing career, and then merch too on our Etsy and Shopify store. Thanks again for watching, and we'll catch you next time. Bye-bye.